Hello and welcome back. We are going to be working on Chapter 30B. These are chest injuries that are cardiac specific. So you should be completing your Chapter 30 workbook in the 12th edition. And in the 11th edition, of course, as you see in the title, it says Chapter 29. Little reminder of anatomy and physiology, which we covered recently, is the thoracic skin, muscle, and bones, the similarity to other regions. And it's also unique in that it allows for ventilation, like striated muscle here in the diaphragm. Additionally, the heart and great vessels and the lungs are in this cavity and are well protected by all of the bony structures. Recall also that the neurovascular bundle lies closely along the lowest margin of each rib, so highly vascular area that can affect respirations as well as the cardiac system. And of course, the pleura that covers each lung and the thoracic cavity. So there's a little bit of fluid between the parietal and visceral pleura that allows the lung to expand and to contract, expand and contract without causing a lot of friction and thus wear. Vital organs like the heart are protected by the ribs. It is connected to the back, in the back to the vertebrae, and connected in the front to the sternum so that it doesn't bounce around inside the cavity. The mediastinum, aka mediastinum, contains the heart, great vessels, esophagus, and trachea. A thoracic aortic dissection, which is something we talked about in previous classes, can develop in this area of the chest, and it would then impact the rest of the great vessels, the esophagus, and the trachea, in addition to the heart. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. It is also an automatic nerve response to breathe, as it is a voluntary response to breathe. We can control our respirations. So there's two types of injuries to the chest, open and closed. In a closed chest injury, the skin is not broken, generally caused by blunt trauma. Closed chest injuries can cause significant cardiac and pulmonary contusions. The heart itself definitely can experience a contusion or a bruise that damages the muscle and prevents it from working appropriately. If the heart's damaged, it may not be able to refill with blood, or blood may not be pumped well enough to force out of the heart into the rest of the body. Lung tissue bruising can result in exponential loss of surface area, and of course, rib fractures may cause further damage, either through penetrating the organs or by bleeding into the area where the organs are, thereby compressing them. In an open chest injury, an object penetrates the chest wall itself, whether it is a knife, bullet, piece of metal, broken end, or fractured rib. Do not attempt to remove the object unless it is impacting your ability to provide CPR to a patient. Blunt trauma to the chest can cause rib, sternum, and chest wall fractures, bruising of the lungs and heart, damage to the aorta, and vital organs can be torn from their attachment places within the chest cavity as well. Signs and symptoms include pain at the site of injury, localized pain, aggravated or increased with breathing. Also positionally, maybe sitting up or laying back may increase pain. Bruising to the chest wall, crepitus, which is that grating palpation feeling with palpation of the chest, and then penetrating injury to the chest, and of course, difficulty breathing. Blood in the spit, aka hemoptysis, is also a possibility. Failure of one or both sides of the chest to expand normally with inspiration. Rapid, weak pulse, and low blood pressure. Cyanosis around the lips or the fingernails would be an indication that perfusion is not happening. Chest injury patients often have rapid and shallow respirations because the pain, because of that neurovascular bundle fractured ribs, can cause significant pain, so it hurts to take a deep breath. They may not be moving air secondary to the pain level. Auscultate multiple locations to assess for adequate breath sounds. And of course, our deadly dozen chest injuries: airway obstruction, bronchial disruption, diaphragmatic tears. We've talked about those previously. Esophageal injuries are basically tearing that causes profuse bleeding within the internal part of the thoracic cavity. Open pneumothorax and tension pneumothorax we discussed in the respiratory component. Massive hemothorax we also discussed. Flail chest we will recover again. Cardiac tamponade is new for this section. The thoracic aortic dissection we talked a little bit about from the medical perspective. From the trauma perspective, it's usually a little more dramatic. And then myocardial contusion, which is bruising on the myocardium itself. And of course, pulmonary contusion we discussed a little bit at our last chapter coverage of this chapter. Protective membrane, basically the pericardium, is a sac that is filled with a small amount of fluid in order to prevent friction as the heart beats, constantly contracts and expands and contracts and expands. What happens in cardiac tamponade is that the area beneath the pericardium starts to bleed, whether it's due to the muscle damage or it's due to a pericardial tear, and that starts to fill with blood. So as it fills with blood, then it inhibits the ability of the heart itself to be able to expand. And so it can't fill with blood to pump out to the rest of the body. And remember, we talked about the Starling reflex, that rubber band theory where the heart expands, and the better equipped the muscle is to expand, it will then contract more forcefully, pushing the blood out to the rest of the body. Well, the pericardial tamponade or the cardiac tamponade prevents that expansion from happening, so there is less blood that will get pumped out to the body as a result. And eventually it can affect it to the point that blood stops flowing to the rest of the body unless that cardiac tamponade is relieved. The only way to relieve that is to get them into the emergency room. They don't necessarily need a surgeon to relieve a cardiac tamponade. They can use a very large syringe and enter into the pericardial space and draw off that additional fluid. However, the surgeon does become necessary if the bleeding continues and the pericardial sac continues to fill with blood even after it's drained. So here's a picture of a normal heart with the pericardial sac in the pericardial tamponade, cardiac tamponade, where it is filled with fluid around the heart. Signs and symptoms, there's a specific triad to be familiar with. So you have a rapid deceleration injury and or a penetrating chest injury or a crush situation, and your patient is now has low blood pressure, identified jugular venous distension. Here's a good picture of that. And muffled heart sounds, which you, instead of hearing that clear lub dub, it sounds much more muffled, as if you were listening to it through a pillow. Altered mental status and narrowing pulse pressure. So now we're collecting blood pressures, and say we have a 120/80. The pulse pressure is the difference of 120 minus 80. So that difference, the pressure between the systolic and diastolic, if it narrows, meaning maybe the first blood pressure is 120/80, the next blood pressure is 110/90, the next blood pressure is 100/95, that would be an example of a narrowing pulse pressure. Kind of an exaggerated one, but it is a narrowing pulse pressure. So you're looking at that change over time. So every 5 minutes, if you're taking the blood pressure and you note that the systolic and diastolic blood pressure are getting closer and closer together, and the patient may be a candidate for a cardiac tamponade, then certainly you should be considering this as a possible cause of their current distress. Support ventilations and rapidly transport. That's really all that we can do for these patients. They need surgeons. They need emergency rooms, and they need surgeons. Blunt myocardial injury can cause bruising of the heart muscle, aka the cardiac contusion. The heart may be unable to maintain adequate blood pressure because the pump isn't working, because the muscle is so damaged it stops working. Signs and symptoms may include irregular pulse rate, chest pain, or discomfort. A cardiac contusion can cause irregular pulse rate or arrhythmias that can be life-threatening due to the nature of the injury, the sensitivity of the cardiac muscle in response to that injury. So suspect blunt myocardial injury in all cases of severe blood injury to the chest. Monitor the pulse, note changes in blood pressure, and supplemental O2 titrated to a 94% or above. Commotio cordis is an injury that is caused by a direct blow to the chest during a critical portion of the heartbeat. So at the junction of the T of the ventricles repolarizing, a hit is received into the chest, and that will basically throw it into a bad rhythm, usually VFib or in VTAC. It does or it can result in immediate cardiac arrest, and VFib responds positively to defibrillation, but within the first 2 minutes of injury, and should not delay onset of CPR. So in class, we'll have this great video to demonstrate to you about that potential for commotio cordis. Laceration of the great vessels can result in fatal hemorrhage. Pre-hospital treatment includes ventilatory support, supplemental O2, immediate transport. Shock is a potential for sure, and then baseline vital signs. So that's all we have for you today in 29B, aka 30B, chest injuries. We will see you in the next chapter.